welcome everyone. We have Dr. David Eisenman with us today. He completed his MD at the Yale School of Medicine in 1992, followed by his residency at the Manhattan Eye, Ear, and Throat Institute, and then completed a fellowship in neurotology at the University of Michigan. And he was willing to give us a grand rounds today, and so we're really looking forward to your talk, Dr. Eisenman.
Thank you very much, Sudhir. Are you seeing my pointer here also?
Yes.
Sure. Okay. Thank you very much. It's my pleasure to be here. It would have been nice to be in LA too, but this is certainly a lot easier. We're going to talk about sigmoid sinus wall anomalies today, and how the story of how those developed has given us a good, broader model for understanding pulsatile tinnitus in general. I have no disclosures, so we'll start with a little background and the story of how sigmoid sinus wall anomalies were first described and detected and treated. We'll talk about how it came to be known that they were strongly associated with idiopathic intracranial hypertension. We'll talk about a story that developed in parallel with the surgical story, which was the interventional story treating pulsatile tinnitus from an endoluminal approach. And then we'll talk about how the merger of those two stories gives you a much better understanding of pulsatile tinnitus in general and gives you a model for understanding and evaluating pulsatile tinnitus. So sigmoid sinus diverticulum was first described by Emmanuel Hudart, a French neurointerventionalist, in a case report in 2000. Here was a CT image. Here was his endovascular image showing lesion, and then he coiled it. And I assume there was a stent underneath this also, because you need to put something in to prevent the material from falling out of the diverticulum, but I don't see it there. And that was successful in relieving this patient's pulsatile tinnitus. A little after that, Doug Maddox wrote an article where he described 5 patients whom he saw, 3 of whom he treated surgically. There was one, there was one, there was one. Notice this ratio, even at a low N, which holds up, that they're about 2 to 1 on the right side as compared to the left side. Doug described a variety of approaches to treating these in these 3. Each one was a little bit different. Shortly after that, we described what we call sigmoid sinus dehiscence in addition to diverticulum. It can occur alone, or it can occur along with or in addition to diverticulum. The story was a little bit funny. We have our tinnitus habituation program here. There was a guy who came down from Connecticut for that program, and the audiologist who was talking with him thought there was something funny about his tinnitus, so she sent him up to see me. And in fact, he wasn't having a conventional central non-rhythmic tinnitus. He had a synchronous pulsatile tinnitus. I had read Doug's article just a little before then. I sent the guy for a CT or some type of imaging, and the findings were, they were weird. Like, it didn't look normal, but it didn't look like one of the diverticula that he had described. So I said, I'm not sure what's going on. I think something's funny. Why don't you go down and see Doug Maddox? He had already come from Connecticut to Maryland. He would just continue on his way and go down to Georgia. And I thought that would be the last of it. Either Doug would say there was nothing wrong, or Doug would say, yeah, that's abnormal, and he would fix it. But lo and behold, a few weeks later, the guy shows up on my door again. He says, yeah, Dr. Maddox said there was something wrong. And I was like, why didn't you just stay down there and have him fix it? But in fact, he came back to me, and we operated on him, and it was successful. And because of the subtleties there and the challenge in making that diagnosis, we described a few things that sort of should catch your eye to make it easier for you to pick out a dehiscence. These are not pathognomonic, they're not definitive or diagnostic, they're just sort of little signs that can help you see that something wrong is going on. So we talked about irregularity of the normal contour of the sinus wall, so it's usually a fairly semicircular kind of thing. This person, you could see it popping out there. One thing we didn't describe precisely then, but is also a nice little sign, you'll not uncommonly see sclerotic mastoids or an atatic sigmoid, where the sigmoid is right under the mastoid cortex. But usually when that's the case, you don't see air cells behind the sigmoid. You don't see a retrosigmoid air cells. With these patients, you can see sinus in the mastoid cortex, but you have these trapped air cells behind it. They're obviously not trapped. They're communicating somewhere, but radiographically, that's what they look like. You can see focal thinning of the caldarium cortex overlying the sinus. And of course, almost by definition, you have the absence of the normal thin layer of bone over the sinus. So here there's thin bone, here there's thin bone, there's no bone. And then what we call the air on sinus sign, where you see air cells that look like they're just sitting right on the sigmoid sinus. And then at the same time, we described a standardized transtemporal approach that we'll talk about that worked for diverticulum and dehiscence. So we called the two of these together, diverticulum and dehiscence sigmoid sinus wall anomalies. That name also allows for inclusion of other things that are less, don't fit neatly into one of those, like ectatic sigmoid sinuses. And there are groups, especially one group in China that has worked a lot on this sigmoid sinus ectasia notion. You could have sigmoid sinus wall anomalies that will compromise diverticulum or dehiscence. There were studies that have shown they are very uncommonly found on routine CT scans. People did retrospective studies, looked at a few hundred CTs done for other things. Very uncommon to see these. And then if there were CT scans done for pulsatile tinnitus, they were the most common findings seen on many of those. They're strongly associated with IIH or signs of IIH, which we will talk about. And they're surgically treatable with a high rate of success. Early on, that was even. There are many larger studies even now. So sinus wall reconstruction, it's a pretty straightforward procedure through a conventional mastoidectomy approach. Depending on the nature of the pathology, it can take anywhere from an hour to 2 hours. That's with residents or fellows. If you don't have a resident or fellow, it may be shorter. We observe them overnight. We get a CT scan on the night of surgery, a contrast-enhanced CT. We want to look at the postoperative flow through the vessel. We do a low dose of anticoagulation. We did not do that initially. And if you look at the early series, some of the complications we had with intraluminal thrombosis, I think there were 2 patients out of the 40. Since starting that, we've only had 1 patient who has had a thrombus, and she's someone I'll show you her images later. We were kind of expecting it. Here's a little just cartoon description of the procedure. There's a right side mastoidectomy. You want to skeletonize the diverticulum, but just as importantly, you want to skeletonize some normal sigmoid sinus around the diverticulum, because that lets you know where the sinus should be. Often with the sessile diverticula, you can reduce them easily with bipolar cautery. The lobulated ones, it's a little trickier. The big ones, it's a little trickier. We then put a soft tissue graft on the sinus, deep to the bone in the epidural space. The sinus wall is very, very thin and fragile in many of these cases. And this, I think, helps to strengthen it. It will also help prevent some of the bone materials from migrating into the epidural space potentially. And then we cover it with bone cement. And now we also usually cover it with a layer of bone dust also. Here's a lobulated right-sided diverticulum going through the cortex. There's the abnormality. Here's what it looked like intraoperatively. You can see normal sigmoid sinus there and there. Proximately, you can't always get a lot because they're usually right at the transverse sigmoid junction. You'd have to go further back, which you could do if you wanted to. I don't think it's usually necessary. Here it is reduced. You can see where the diverticulum had expanded the bone. This is middle fossa here. The dura is not exposed here, but sometimes the sinus will expand and erode away the bone. So you're right on middle fossa dura. And here was an alloderm graft that we put reconstructing the entire sinus wall. This is bigger than usually needs to be done for these. And there you can see where that was. And this is now the bone cement and the bone dust on top of it. We're not trying to obliterate the whole mastoid. We're just trying to resurface the sigmoid. Sometimes it ends up close to a mastoid obliteration, though. Here is a nice video that will look at all this for us. This is a left-sided diverticulum, which you can see there. Intraoperatively, it's regular complete mastectomy approach. You really want to make sure you have exposure superior, posterior, inferior, around all sides. Anterior to it is hard because if this thing is protruding, it's hard to get around that front wall, as you see. But you have to get up above them. You want to get behind them. We're skeletonizing some normal sigmoid below it and a little bit behind it here. This area where it's protruding, you guys do a lot of trans labs, obviously. You know how to drill on a sigmoid. This is much more fragile than a usual sigmoid. You have to change your technique and how aggressive you are. Here, I would say I made a little mistake. People don't usually show their videos with surgical mistakes. I should have thinned this a bit more because you're going to see what happens as I pull it off. We're getting a little bleeding from the fragile diverticulum. Not a big deal. I'm going to put it back just while I get whatever I need ready. We're going to put some, looks like I was just using a patty. And now I'm using the bipolar on top of the moistened patty, keeping it wet. We can reduce the whole thing. You can see where the diverticulum was. You can see the normal layer of sigmoid. Here's some normal sigmoid there. We'll get rid of that bone. You don't really have to, but looks nicer. And now we're going to have to replace that patty with some hemostatic agent so that we can finish it. So I'll just cover that over. We'll tuck that under the front wall. This is why it's important to have normal sigmoid around you so you know where you want this to be. And then you can get the patty out and tuck it along the back. And this is just a soft tissue graft. This is a Biodesign porcine submucosa. They're a little thinner than the neuroalloderms that we used to use. You could certainly use temporalis fascia, which I used to use all the time. There it is reconstructed. And then we put the bone cement on to repair the bony dehiscence. I'm going to partition off the additives to make sure that stuff doesn't go in there. That hardens. I put some gel foam in the additives to prevent the bone dust that we're going to use next from going in. And then this was just autologous bone dust that we harvested during the approach. I'm going to take it. This is not going to show it, but I really want to cover it up. Yeah, there it is over there so that during the closure, you don't fracture the bone cement. And then I put a little fibrin sealant on it just to help hold it in place for the closure. So this one came closer to a mastoid obliteration, depending on the size of the mass, that they don't always look like that. And you can see here, there's the reconstruction. There's a little extraluminal compression of the vessel, probably from that new knit with some of the flow seal, but there's still good flow through the vessel. And this patient was fine, no symptoms of elevated intracranial pressure. Here's some other ones: a right-sided diverticulum, pre-op, post-op, a right-sided dehiscence, pre-op, post-op. So we published this a little while ago now, 7 years ago, the first 40 years, 38 patients, 40 years, comparing patients with diverticulum and dehiscence. You might think they were different populations. We couldn't find any variables by which they differed, neither age, duration of symptoms, nor BMI. 90%, 36 out of the 40 were successful responders. All of the patients who had a diverticulum, the surgery was successful. Patients with dehiscence, there were 4 patients who was not successful. There was no difference in age, symptom duration, or BMI between the responders and the non-responders. This is updated more recently, 108 years, 94% success rate now, 6% who did not respond. We have 1 patient with a diverticulum who don't know why she didn't respond. That one is still a mystery to me. She had all of the right features and her PT is still there. We haven't found any other cause. 1 patient who had an undiagnosed AVM, as soon as she clearly had a sigmoid sinus dehiscence, as soon as I got in there were all sorts of small transcortical bleeders. I knew something funny was going on. We did the operation, we repaired her, she was no better. We took her to IR, and in fact, she had an AVM. 1 patient who initially failed with dehiscence and then got stented and responded. She had a superior semicircular canal dehiscence. which presumably what was happening was she was just that much more sensitive to hearing whatever was causing the sound, meaning her transverse sinus stenosis. And we will talk a lot more about that in just a minute or two. There are failures. The most common causes are incomplete resurfacing or failure to identify multiple areas of dehiscence. That's why you really need to see everything. Don't just zoom in on the diverticulum and go for it. You have to have a broader view to make sure you're not missing something else. And then, of course, failure to identify other potential contributors. And then in some people, they can have a transverse sinus stenosis causing a sound that's so loud that even when you reconstruct it, they can hear it through that reconstruction, right? My door is closed right now. There might be people outside talking and I don't hear them, but if they were screaming, I could hear them even through the closed door. If they're speaking softly and I open the door, I'll hear them. So it just depends on how loud the sound is. We're going to talk more about this in just a minute. So at some point along the way, we realized that the same people who we were operating on for these sigmoid sinus wall anomalies, they seem to have a lot in common with the population who's susceptible to IIH, idiopathic intracranial hypertension. They had elevated BMI, predominantly female patients. Elevated BMI males are much less common. Here was one example. She had an empty sella. She had a middle fossa encephalocele. She had a sigmoid sinus dehiscence. We repaired it. Her pulsatile tinnitus got better. We did a middle fossa and repaired her with a titanium mesh plate. Nowadays, this was a little while ago. Nowadays, I would have repaired both of these through a transmastoid approach, one operation. You fix the two problems in one shot. We showed that there's a very high rate of transverse sinus stenosis in these patients. And then we quantified it, comparing the degree of posterior venous outflow obstruction between the sinus wall patients, normal controls, and patients with IIH, historical data from patients with IIH elsewhere. And we showed this is a combined conduit score. It's sort of a measure of their outflow. Lower number means worse outflow. Normal controls, or whatever that number means, the sinus wall patients were significantly worse, but not as worse as the IIH patients are. So they have posterior venous outflow stenosis, but not as bad as patients with IIH. We then looked and tried to figure out, well, why did some people not get better? We already had seen that all of the non-responders had a unilateral dehiscence. It happened they were all on the left side. I don't have a good reason for that. None of the non-responders had transverse sinus stenosis or empty sella, meaning these other signs of elevated intracranial pressure. And in fact, statistically, you could only look at this in the dehiscence population because all the diverticulum patients for this study had been successful. So the patients with dehiscence, absence of transverse sinus was associated with failure to respond to surgery. Absence of empty sella was associated with failure to respond. So just to summarize where we were now, we knew we had this group of patients with this radiographic finding of a sigmoid sinus wall anomaly. We knew that they had a lot in common with patients with IIH. And we knew that we could operate on them and it had a high rate of success, but maybe only in the patients who had the IIH findings, not people who had a dehiscence without the IIH findings. So at the same time that this was all going on, there was a parallel story developing in the neurointerventional world. There were a lot of studies coming out on transverse sinus stenting, endovascular treatment of tinnitus, pulsatile tinnitus, for patients with transverse sinus stenosis. This is both in the neurointerventional literature, started coming into our literature as well. So these were patients. The neurointerventionists were already stenting for patients with IIH, but now they were finding people with pulsatile tinnitus alone, without IIH, and they were putting in transverse sinus stents for them, and they were working. Athos Patsalidis, who was up at Northwell in Long Island, noticed a few things that other people did not notice. First of all, he compared the type of stenosis in his IIH patients to his PT patients, whereas in the IIH patients, it was an extrinsic extraluminal compression in many of them, and some of them it was intrinsic, meaning an arachnoid granulation. In the PT patients, almost all of them were arachnoid granulations, not extraluminal compression. He also noticed that many of them had what he called a saccular venous aneurysm distal to the stenosis in the distal transverse or proximal sigmoid sinus. Many of the PT patients had that, about 25% of them had that, but very few of the IIH patients had that. Now, the neurointerventionalists most commonly are doing their evaluations with MR-based studies. They don't usually do CT, so they're not going to see bony abnormalities usually. So you can imagine if you're looking at something from an endoluminal perspective, and you saw a dilatation, you would call that a venous aneurysm, a saccular venous aneurysm. If you were looking at that on bony imaging, you might call that a sigmoid sinus diverticulum. And in fact, these saccular venous aneurysms were sigmoid sinus diverticula. He took it one step further in a later study when he looked at those so-called poststenotic aneurysms, or we might call them diverticula. A bunch of them were saccular, but the majority of them were what he called fusiform aneurysms, meaning there was a dilation, a non-saccular dilation of the proximal sigmoid sinus. And it is the case, we know now, that all of those are actually sigmoid sinus dehiscences. They're ectatic, expanded sigmoid sinuses with dehiscence of the sinus wall, but they're not seeing the dehiscence because they're doing only MR-based imaging. And in fact, every single one of his 42 patients who he had stented had a sinus wall anomaly. So you're seeing the same and let me just point out that their success rates are great with transverse sinus stenting, around the same as with sinus wall reconstruction, 94%. This is a systematic review that looked at it. So you're seeing, and complication rates also are fairly similar. I'll just say this before we go on, but the complications differ. Our complications are most commonly persistent pulsatile tinnitus or some outflow stenosis. Very, very rarely is it symptomatic, but sometimes it can be a small percentage. In those patients, we just extend the anticoagulation. Endovascular therapy complications can be a little more serious. Stent stenosis or juxtastent stenosis. There are patients who have had hemorrhage. I know of patients who have died after stenting for pulsatile tinnitus. You can thrombose your stent. They need to be on anticoagulants for a lot longer, and you can have complications of the anticoagulation. And there are studies, cases showing when you stopped anticoagulation later, you thought you were out of the woods, they can re-stenose. So overall, the rates are similar, but I may be biased, but they seem to me a little bit worse. But what this story, this is, let me just show you one complication from a surgical side. This is a pretty big diverticulum. We were expecting to have problems with her. She had no transverse sinus on her other side. So I personally would be hesitant to stent this on her only transverse sinus that was already patent. It wasn't really even stenotic. Because if you have a complication, then she's got nothing. Here's her MRV. You can see it's so large that you could see it there. Here you see there was nothing on the other side. Here's her pre-op, here's her post-op reconstruction. What you can see or what you can't see is this is a contrast enhanced CT. You don't see flow in the sinus. So she had a thrombus, and in fact, she was having mild headaches and grade 1 papilledema. Nothing life-threatening, nothing to go crazy about. We just extended her anticoagulation, and a few months later, she recanalized. She still was not as big as she had been, but she probably shouldn't have been as big as she was, and she's completely asymptomatic now. No pulsatile tinnitus, no signs of intracranial hypertension. She's off of anticoagulants, and she just sent me a present. She's very happy. I would point out, though, also, we mentioned before that some people will just, well, actually, we'll talk about that in a second. So what it seems from the sort of clash of these two stories, the sigmoid sinus wall anomaly story with transmastoid surgery and the endovascular therapy transverse sinus stenosis story, these are two procedures being done on the same population, and they both have a good success rate. What that tells you is that there are two requirements for pulsatile tinnitus, each of which is necessary, but neither one of which is sufficient to cause the pulsatile tinnitus. You need something to make noise, in this case, transverse sinus stenosis. You need something that lets you hear that noise. In most cases, a sigmoid sinus dehiscence. You might have thought that the diverticulum was what was making the noise, but it's really not the case. Every symptomatic diverticulum that you will see also has a dehiscence overlying it. You'll see diverticula that are completely covered by bone. I've never seen a symptomatic one that was completely covered by bone. They all have some dehiscence. That and many people will just cover the dehiscence without doing all the stuff that I showed you earlier, decompressing and et cetera, et cetera. The problem with that approach is if you look here, here's her dehiscence, you're not going to be able to reliably cover that. You're coming from here, or even from here, you can't drill away this bone adequately to resurface the undersurface. So that approach is not always viable. But these two procedures, the endoluminal procedure, the transmascular procedure, they're both treating it, but they're treating opposite sides of it. This is getting rid of sound production. This is making it so you can't hear the sound. So generally speaking, our approach has been, if someone has only pulsatile tinnitus with no signs of IIH, we give them the option of a transverse sinus stent or a sinus wall reconstruction. Most patients take the sinus wall reconstruction. There are a lot of people who don't want stents and don't want long-term anticoagulation. If someone has symptoms of elevated intracranial pressure, we for sure send them for transverse sinus stenting. But this model helps you understand lots of other things. There are many things that can make noise, and there's some things that don't make noise, but they let you hear noise. And we'll look at this a little bit more closely. When you're thinking about causes, so-called causes of pulsatile tinnitus, you shouldn't really be thinking about what causes it. You should be thinking about what are things that can contribute to it. What can make the noise? What can let me hear the noise? And sometimes it can be more than one thing. The patient I showed you before, she had transverse sinus stenosis, or I mentioned it before, transverse sinus stenosis, sigmoid sinus dehiscence, and a third mobile window. We fixed these two. We fixed this one. She still had pulsatile tinnitus. She got stented. Remember, I'm pretty sure she also ultimately needed her third mobile window treated, because even with all of this, she still had some turbulent flow and she was so hypersensitive to it. So you have to think about what are things that can contribute to pulsatile tinnitus. This is not something where you can just look at it and say, this is what your cause is. You always have to think more broadly about what could be contributing to the cause. This model is nicely illustrated here. My wife and I every week go for a walk by a creek near our house. And what you notice when you do the same thing every week is that the noise of the creek changes. Sometimes it's louder, sometimes it's softer. If there's a rock there, you get turbulent flow and it's louder. If you have a log blocking it, you'll get upstream turbulent flow and it's a little louder. If it rained the day before, it gets really loud. If you're walking past a wall on the path by the side of the creek, the sound gets softer. If there's a break in that wall, then the sound gets louder. All from the perspective of the observer on the side. If you pitch a tent and you're sitting in the tent, so you're masking out the birds and the crickets and all the other noise, it sounds even louder. And if for some reason you decide to take an ear trumpet with you, it gets even louder. And all of these have physiologic correlates. If we just think about them from the venous side right now, transverse sinus stenosis, jugular vein stenosis, or other things obstructing posterior outflow from central venous pressure, high flow states like anemia and hyperthyroidism. An intact sigmoid wall is going to mute the sound. A dehiscence is going to make it louder. If you have a conductive hearing loss and you're not hearing other stuff going on, you're going to hear your body somato sounds louder. And if you have a third mobile window, all of those are amplified even louder. So if we look at this diagram, this model, you can divide it into two parts. You have the stuff in the water. Those are the sources of sound production. These are venous side. If you think of arterial side, you have carotid stenosis, fibromuscular dysplasia, whatever. And then you have the stuff up on the shore. These are the things that are letting you hear it. These are what are giving you cochlear access. The stuff in the cloud, which ultimately goes into the river, you're not going to image. Those are things that have to be evaluated separately. So this gives you a good explanation for why there are so many things that we see that don't usually cause pulsatile tinnitus, but sometimes they can. I have never resurfaced a carotid for pulsatile tinnitus, but there are people who have, and it has been successful. But we see carotid dehiscence on a daily basis that is asymptomatic. Carotid stenosis, hundreds of thousands of people walking around with atherosclerotic disease in their carotid artery. Most of them don't have pulsatile tinnitus, but some of them do. Well, maybe those ones also have hyperpneumatized temporal bones with a dehiscent over the carotid that's allowing them to hear that sound. You need to look for that. We need to find some reason why some patients with carotid dehiscence have pulsatile tinnitus when most don't. Same thing with the jugular bulb dehiscence. It's a routine daily finding on our CTs, almost always asymptomatic. Maybe the ones who are symptomatic, and there are people who have done jugular bulb resurfacing successfully, they must have something else that's causing the noise that you're stopping. Maybe a jugular vein stenosis between C1 and the styloid. Anemia, most people with anemia don't have pulsatile tinnitus, but some of them do. You got to take a look at their temporal bone to see if there's some reason why they're more susceptible. Same with hyperthyroidism, suprasemicircular canal dehiscence. I think it's only about 15% of patients with supracanal dehiscence who have pulsatile tinnitus. Those 15% probably have some other source of sound production, whether you see it or not. Same with eustachian tube dysfunction. I've had people with eustachian tube dysfunction, pulsatile tinnitus. You put a tube in their ear and they're fine. I haven't done anything to manipulate a vessel. They're just no longer hearing whatever sound they had been hearing. Same with otosclerosis, and the list could go on and on of things or combinations of things that could contribute to pulsatile tinnitus. So this leads you to the next question, which is a very important one that gets asked all the time. What's the best imaging test? When you're asking this question, what you really are asking is, what's the best imaging test when the cause is not evident on physical exam or audiometry? Right? If I look in somebody's ear and I see a vascular mass on the promontory and I can see it circumferentially, I'm not ordering any imaging for their pulsatile tinnitus. If I can't see below it, well, I know what my protocol is for a jugular foramen paraganglioma. That's what I'm doing. That's not a question of what's the best imaging test for pulsatile tinnitus. That's a question of how do you image a suspected jugular foramen lesion. That's a different question. But what's the best imaging test for isolated pulsatile tinnitus? So if we look back at that diagram, the cartoon, we have the stuff in the water, we have the stuff on the shore. The stuff down here is going to be best imaged with some vascular studies. The stuff up here, you need to look at the temporal bone. So if you look at, here's what, 8 or 9 common contributors to pulsatile tinnitus. I'm not going to call them causes, but they're contributors. How do these stack up? These are some of the most common things that people do. Temporal bone CT, you're going to actually do pretty well, but you're going to miss all of your vascular stuff. You'll see some of the soft signs of a dural AVM, but not everything. MRI, it's not even quite as good, but this is much more commonly ordered than a dry temporal bone CT for some reason. MRA, even worse. This is probably the most common study that we see people come in with. CTA, you're pretty good, but you're not going to see fine bony anatomy, and because it's only arterial, you may miss a transverse sinus stenosis as well. So we developed a single protocol. It is bone windowed like a temporal bone CT with thin cuts through the temporal bone. It's contrast enhanced, but we delay the injection to make sure there's also venous filling. And we extend it into the upper neck so we can see the distal carotid and the proximal jugular vein. This is the protocol. This is where it was published. This is the protocol. If you can't find the article, I'm happy to send this to you. If you look at that, how that stacks up against all the others, this is going to show you every single cause of these most common causes, and even more. If you look at a broader list of things on either side of the sound production or sound perception part of the story, or combinations, which you'll see commonly, This modified protocol is going to show you everything that can show up on imaging. Migraine, Meniere's disease, both have been associated with pulsatile tinnitus. Those are not typically diagnosed with imaging. Anemia, hyperthyroidism, not typically diagnosed with imaging. Those, of course, you need to look at other things. And it's probably why it's probably not a bad idea on every patient to just do a CBC and a TSH to make sure you're not missing some other contributor. Even if you find some other cause, that doesn't mean there's not something else contributing. We have looked at this. The way we studied it was we looked at a group of it's about 90, 87 patients who came. Half of them had previously been imaged and it didn't show a cause, and half of them had no prior imaging. They were all imaged with our protocol, and the sensitivity, specificity, PPV, NPV of the study was the same, very high, and it was the same in both groups, implying that there was nothing that was being picked off earlier by that prior imaging that the patients had had. So this seems to be a very good, highly sensitive, very highly specific study for at least initial evaluation of patients with pulsatile tinnitus. So in conclusion, sigmoid sinus wall anomalies are a common and treatable cause of pulsatile tinnitus. They are very commonly associated with transverse sinus stenosis, and that's important because that is probably what's making the sound that you are hearing through the anomaly, and they're also associated with other features of IIH. In all patients with PT, you should look for a source of sound production and a source of sound perception, meaning a route of cochlear access. And a modified CTA is a very effective imaging solution for looking at both of those components, both of those potential contributors to pulsatile tinnitus. Thank you.